So we are continuing in the program with another sort of specialty area, and that's pediatric surgery. But there are some really important issues when we use energy in pediatric patients, and nobody's better prepared and situated to tell us about that than Dr. Purcell Jackson. Thank you, Gretchen, for coming.
Thank you.
Forward.
Great, thank you very much. I'm going to spend just a few minutes talking about special considerations for using energy devices in pediatric patients. I have nothing to disclose. Now, I couldn't give a talk about pediatric patients without saying that children are not small adults. They may look like smaller versions of their adult counterparts, but they have unique anatomic and physiologic characteristics that need to be taken into account when you're using energy devices in this patient. Now, most of the people who operate on children are over at IPEG, so most of you probably don't spend a lot of time or any time operating on children, but you probably do operate on people with altered anatomy or body composition, and people with amputations or cachexia or severely edematous patients who are very sick and require emergent operations may have similar features that you have to take into account. So I hope some of the information that I'll give you will be relevant to you. When compared with adults, infants and children have a greater body surface area to volume ratio, but they have less total body surface area. So what this means, less total surface area, means less room for all of your monitoring devices, dispersive electrodes, and other things that you need to have on the patients. What it also means is that areas of high resistance tissues are located in close proximity to tissues of low resistance, so the path for your current may be much less predictable than it is for an adult. Second, current flow is highest in tissues of high water content. We've heard that, and children, especially newborns, have significantly more total body water, making tissues low resistance and thus good conductors of current. So as you all know, adults have about 60% total body water. Neonates are born with an excess of total body water, a lot of which they lose in the first week of life, but they still maintain that for the first couple years of life. So a term neonate is going to have about 75% body water, and if you have the occasion to be interacting with some of these preterm infants or small for gestational infants, like a 23-week or 24-week, some of these infants do survive and do require operations from complications of their prematurity, they may have as much as 90% total body water. Finally, these patients have smaller anatomic structures requiring smaller instruments, and as we've learned today, both of those concentrate current in critical areas. And with the small size of these infants, any injury or burn can be really catastrophic. So another issue for pediatric patients is that the small diameter airways in infants and children are at particularly high risk for operative fires. Again, as we heard earlier today, you're combining combustible materials and an oxygen-rich environment in a very limited space. So there's several precautions that you can take to reduce the risk of fires, and I think, again, when you're dealing with these patients, you want to have that little powwow before. This is a high-risk situation. Talk about what you can do to prevent a fire. So for younger children, an appropriate sized, for the older children, usually above 8, will be using cuffed endotracheal tubes. That can separate your upper and lower airways. But when you're operating in the younger children, you want to use an appropriate sized uncuffed tube to avoid a large air leak, which could increase your nitrous oxide or your oxygen concentrations at the operative site. And these are for your oropharyngeal procedures. Now, as talked about in an earlier talk, if someone has a comorbid cardiac or pulmonary condition where you really have to use a high concentration of oxygen, then you might want to avoid electrosurgical devices altogether, or at least the modulated and high voltage coagulation waveform, which is prone to sparking. All right, electrosurgical settings. The one reason that I actually volunteered to give this talk way back when we were starting Fuse is that I wanted to know, what should I be setting my devices at? I've never seen that written down, and nobody's actually instructed me to that. I will say that there isn't any pediatric surgical literature on this, and as you've heard throughout the session, you want to try to use the lowest settings that you possibly can to get the desired thermal effect. Now, I will say that in pediatric surgery, I operate on from 500 gram preemies to 500-pound teenagers, and I rarely use settings that are above 10 or 15. So the power settings that are above 10 or 15. And you can get the results that you want even in the larger teenagers. What's important when you're operating on neonates is that most of the time devices should be calibrated specifically to measure your maximal power setting that should be used to achieve a specific current. And I will say that this shows a specific Valley Lab label, and I'm not endorsing any particular product, but I've never seen these used in our operating room, but it is recommended for the devices that each device is individually calibrated by a biomedical engineer, and that's what you need to do to be safe. We've talked a lot about dispersive electrodes. These are available in weight-based sizes for infants and children, and the lower limit is going to be about 1 pound or 400 to 500 grams. When people get above about 30 pounds or 13, 14 kilograms, then you can start to use the adult-sized dispersive electrodes, and there are usually pediatric versions for the weights in between. The size and the proximity of structures in children make that electrode placement challenging. And keep in mind that that neonatal skin is extremely fragile, so when you have to be very careful with the adhesives on the electrodes. If for some reason, and I've had this problem operating on a 500 or 600 gram baby, you could not get the dispersive electrode on in a way that the device would say, the generator would say that it was okay, and in that case you should use a bipolar device. So the guidelines for the placement of these dispersive electrodes are exactly the same as they are for adults, but they weren't repeating for children because the placement is a little bit more challenging. As we talked about before, the ideal site is going to be something that's well vascularized, it's convex in shape, close proximity to the surgical site, and not near any scar tissue or bony prominences or excessive fat. And for a neonate, in general, you want to put it on the back between the scapula and the sacrum. For infants that are a little bit larger, you can put it on the back or the torso or even on the thigh. But all of these, in the smallest folks, in even all children, all of these sites are going to be at risk for pooling of fluids, either from your skin preparation, drainage from your operative site, or irrigation during the procedure. And of course, you have to consider that in adult surgery also, or surgeries where you're going to be using a lot of irrigation, or have a lot of fluid in the abdomen, but it's really important in children. What I usually do in my operations on very small folks is I protect the sites of the dispersive electrodes with fluid-resistant adhesive drapes, as shown on this slide. And the nice thing about these drapes is that they can also help keep the infant warm during the surgical procedure. And what you can't see here, and what I usually do in the babies, is I'll also put one underneath the rectum and where they can pee on the drape so that it's protected from that also. Again, the neonatal skin is extremely fragile, so you have to be careful about that. And then finally, with regard to our very youngest patients, the fetus, there's no evidence that electrosurgery in a pregnant mother poses any risk to the fetus at any stage of development. As it turns out, the amniotic fluid is electrolyte rich, and it helps protect the fetus from current concentration. And as we talked about earlier in the session, the output frequency of the electrosurgical generators is above the level that stimulates muscle contraction for both the adult patient and the fetus. So the only risk to the fetus is if it's directly touched by an active electrode during, say, a C-section. And that's all I have. Thank you very much.
Thank you. Excellent.